Hello, everyone. I am here again today with Bonny Specker, epidemiologist from South Dakota State University, who later is going to give us an update on everything that's been happening with COVID-19 in our area, in the state, in the U.S., and in the world. And also today we have a special guest. Lon is here today, Lon Kightlinger, who is a retired state epidemiologist, who is going to give us a presentation on vaccine efficacy. Thank you so much for joining us today, Lon.
Yeah, well, thank you for inviting me. It's my pleasure. I'm Lon Kightlinger, and I'm here in Pierce, South Dakota, here in the middle of the United States, the middle of North America. And I've worked for over 40 years in public health, and I've worked with many vaccines and seen many diseases, many bacterial diseases, parasitic diseases, and many viral diseases. This is my second pandemic that I've been involved with. But just some of the viral diseases have been influenza, SARS, measles, Zika, West Nile virus, rabies, Ebola, polio, hepatitis, and so on. And I've seen just the morbidity, the ravages caused by these viral diseases. And I've also seen just the astounding results, prevention that have been offered by vaccination. So I've really seen all the great good that vaccines can do. Personally, I've not yet been vaccinated for COVID because my age cohort has not yet come up for vaccination, but I certainly will. Hopefully here in South Dakota, I'll be eligible here in a couple weeks. Mid-February, they're down to vaccinating people 70 years and above, so I should be coming up here pretty soon, and I urge you all not to hesitate to be vaccinated, but then don't jump the line. Wait your turn. They're trying to get this well organized, and we know the vaccine supply is short, so take advantage of it when your turn comes. I've been vaccinated for every other disease. I feel I've been vaccinated 5 times for smallpox. Yes, I'm that old. I've been vaccinated 4 times for yellow fever. However, I've never been vaccinated for measles or mumps because I was born before 1957. So when I was a kid, measles and mumps and those types of diseases were ubiquitous. We all had them, and they took a big toll. Children died from it. People were, brain damage due to influenza. So I'm familiar personally and professionally with vaccinations. Could you flip over to the next slide, please? And then we'll actually start what I want to talk about. Specifically, I'm going to talk just about COVID vaccination, but give some other examples as well. So, but broadly, I'm talking about the prevention of COVID. And there's many ways to prevent COVID disease, specifically vaccination, and then wear a mask, stay 6 feet away from others, avoid crowds, avoid poorly ventilated spaces, wash your hands often, cover your coughs and your sneezes, clean and disinfect your surfaces, and monitor your health daily. Now, specifically about the vaccine, what are the attributes of a good vaccine? First of all, it prevents a bad disease. And then it has high efficacy and high effectiveness. And that's the topic of my little talk here today. A good vaccine, it's safe. It has wide availability. It's available when and where you need it. It's cost effective. It has enduring immunity. The protection it affords lasts a long time. It has multivalent antigenicity. It's easy to administer. It has logistic usability, and it's acceptable by the population. So all these things go into what a good vaccine is. Now, just a little bit more on the background. Currently, we have 66 COVID vaccine candidates that are registered with the World Health Organization, and this is as of Friday. And there are 10 different formulations or strategies that are being used, and these are not just in the United States, but these are worldwide. And only 2 of these have been approved by the American ACIP, and the ACIP is the Advisory Committee on Immune Practices, and that is appointed by CDC, and it's a very a very good scientific group that actually looks at all the vaccines and then works with FDA and CDC and gets them approved and licensed. So we have some that use the protein subunit, that's 22 of the 66. Some use a viral vector. They hook part of the coronavirus COVID onto, like, say, the adenovirus, and then that's injected, or an inactivated virus. This would be a killed virus, or a DNA or an RNA virus, which the two vaccines that are currently approved for use in the United States are, and then several other methods. What we'll look at here is vaccine efficacy, and then the other part of that, which is sometimes confusing, but it really shouldn't be, is vaccine effectiveness. So there's efficacy on one hand, and then the effectiveness, kind of, they're sort of the same thing. And what it boils down to is just how good the vaccine is, how good it works at protecting you from disease. But just to cut through some of the jargon, the vaccine efficacy, what that is, it's the vaccine protection, and you measure it by a randomized controlled trials. And that's what we have up until this point, because those are usually done by the vaccine manufacturer. They supervise that, and they present that to the ACIP, that CDC committee that approves it. They submit that as evidence on how good the vaccine is. Oh, by the way, the ACIP, it meets again next week, and they may approve another type of vaccine. And then vaccine effectiveness. That refers to vaccine prevention measured in observational studies under real world conditions. So what we have now for the COVID vaccine, we have the vaccine efficacy, but then once it gets rolled out and a lot of people get vaccination, in fact, they're already doing it, and then they'll look at how the vaccine works under real world conditions, and then we'll have what we call the vaccine effectiveness. So just to run over some of the vaccine efficacies for some common vaccines that are in current use. Here's a list of some of our favorites. For the measles vaccine, which is really one of the miracle vaccines, one of the best vaccines, one of the near perfect vaccines, I think. One dose of measles vaccine, if you get that when you're a kid, you'll get 93% efficacy. And then for 2 doses, it's 97%. For mumps, 2 doses, 88%. Polio, which is almost eradicated. Please, Afghanistan and Pakistan, get rid of polio. Get everybody vaccinated so we don't have any. But 3 doses of polio, it's 99% efficacious. With chickenpox or varicella, 90% for 2 doses. Hepatitis A, either 94% or 100%, depending on which vaccine you use. Hepatitis B, anywhere from 80 to 100%. Pertussis, or whooping cough, is 80 to 85%. And then tetanus, almost 100%. Hib, the Haemophilus influenzae, another childhood vaccination, 95 to 100%. Meningococcal vaccine, that's for the A and the C subtypes, 85%. The HPV, or the human papillomavirus, 95%, and that's measured by seroconversion efficacy. The shingles vaccine, 90%, and then, oh gosh, influenza, a paltry 19% up to 60%. Okay, just to, this isn't COVID, but I just can't help myself. I had to talk a little bit about the effectiveness of the influenza vaccine, because I think that helps us understand like how rigorous the measurement is and how ongoing this is, and how part of measuring vaccine effectiveness is just part of our built-in public health infrastructure, which I assume in coming years, COVID will be something like this too. But you can see over the past, oh gosh, how many years is that? 15 years or so, the influenza vaccine has ranged as low as 19%. during the 2014-2015 influenza season. Now, the influenza season runs from October of the one year up until April of the next year, roughly. And that year it was really low, but then it goes as high, which isn't really very good, up to 60%. And that was during the 2010-2011 vaccine. Now you get these ups and downs every year because influenza, it's a very fluid vaccine. It's always mutating, it's always changing, it's always drifting, and we always have a different strain that's circulating every year. And it depends on which strain is dominant during that year of circulation, and then how close the vaccine actually is to matching that strain. So that's why we have all this up and down. This past year, it was 39%, which, frankly, isn't that good. But even though it's not perfect, you have to interpret this by saying 39% just probably eliminates all disease. But then what the influenza vaccine does, it also lowers your risk of, you may get sick, but you might not be hospitalized. Or if you are hospitalized, you might not die. So even though it's not perfect, it does lower the morbidity or the mortality. And I wonder what's going to go on this year, because the 2020-21 influenza season has been so mild. We've had so few cases. I think it's going to be very interesting how they measure this. Now, just drilling down as an example here into influenza vaccine effectiveness. And this is the data from some of the stats from last year's measurements here. So we had the number of subjects was almost 9,000 individuals participated in this study. And they were people in 5 states, Wisconsin, Pennsylvania, Texas, Michigan, and Washington State. The closest one was Wisconsin, and that was the Marshfield Clinic group there. And Marshfield health system covers much of central and western and northern Wisconsin. It's kind of like the Sanford or the Avera of South Dakota. And they participated in this study, and they're a good leader in that. So for last year, for all influenzas, influenza A and B combined for all age groups, it was 39%, as I mentioned in the previous slide. The 99% confidence interval for that was pretty wide, 32% up to 44%. And then you can either even drill down even more into that and break it down into the age group. The little kids from 6 months to 8 years of age, the vaccine effectiveness was 34%. For the school-age kids, 40%. For the young adults up to age 49, it was 24%. For the older working-age adults, it was 40%. And then for people over the age of 65, the influenza vaccine effectiveness last season in the United States was 39%. And then you can even pick it apart by which type of influenza we're looking at here. And for influenza A last year, it was 30% for the H1N1. And then for influenza B, Victoria, it was 45%. So how do you do an efficacy study? Well, this is just a very rough example how it looks. And what you have to remember for efficacy study is it's pretty high epidemiologic science. This is a randomized, double-blind case control study here that we have. And it takes a lot of organization. It takes some good science to do. So I'll just show you this example. We start out with volunteers. So we get about 50,000 people to volunteer. And these could be people all across the country, in many states, even all around the world, but they have to use the exact same protocol, the exact same procedure, the exact same vaccine, the exact same placebo, the exact same syringes. Everything is very, very precise and very well calibrated. So these 50,000 volunteers, they go through questionnaires and interviews, and then invariably people are going to be excluded. So we've excluded 20% of the people. 10,000 people have been excluded. They're either too young or too old or too sick, or they can't follow through. They're not going to be able to locate them after several months after the study's done, or they're uncooperative, or they chicken out, or for whatever reason, those people are excluded. So we're left with 40,000 people in our study group, and those people are randomized into two separate groups blindly. They don't know which group they're in. The doctors, the nurses, the epidemiologists, they don't know who's in what group. So we have 20,000 assigned to the placebo group, and they're getting saline injections. And then you're getting 20,000 volunteers randomly assigned to the vaccination group, and they're getting the antigen. They're getting the Moderna or the Pfizer or whichever vaccine you're using. And they don't know. There's a barcode on the vial or a series of numbers, and it's indecipherable to the nurses and the patient, and you just don't know. Patient 1 and 2 could be vaccine, and then patient 3 might be the placebo, and then 4 of them, you just don't know. And then a couple months go by. Let's just say, for example, here 3 months go by, and they go about their lives, and they're out living, and they may be exposed to the coronavirus or whatever disease you're looking at here. And then during that time, they check in maybe once a week or 2 weeks, and they record every time they get a fever, every time they make a clinic visit, any lab tests that they have regarding that, if they're hospitalized or if they die. So at the end of this, let's say 3 months of natural exposure, we look at the placebo group, and we find that, oh my goodness, 10,000 or half of them are sick or have died, and then 10,000 are still well. Whereas in the vaccination group, those 20,000 people, 1,000 have become sick with the disease, and 19,000 are well. So we do some math here, and what we find is that in the placebo group, we had 10,000 sick and 10,000 well, and that gives us the risk in the placebo group is 50%. 50-50. Let's just toss a coin, because that's about all it amounts to. And then the risk in the vaccination group, with 1,000 getting sick, out of your 20,000 total, you get 5% risk there. So you do some math, and shown on the slide there, and you get the VE, or the vaccine efficacy, is 90%. So if here in South Dakota, we vaccinate 100,000 people, get the vaccine, and we're all exposed to the disease, that would mean that 90,000 of us would be well, would be protected, but 10,000 of us would get sick. So that's 90% efficacy. Okay, this slide here, this is what we've been waiting to see here. So this is the COVID vaccine efficacy, and they're measuring lab-confirmed cases, hospitalizations, or death. And this is done by the pharmaceutical company. They carry these out, or they hire scientists to do these studies for them. And they're very large studies, very precise studies, as I've tried to explain to you. So what we have is, first of all, the Pfizer vaccine. 1 dose is 82% efficacy, and 2 doses is 95% efficacy. And this is one of the 2 vaccines that's being used here in South Dakota now as we speak. This is an RNA vaccine. It's been approved for use in the United States, in Canada, in some South American countries like Canada and Chile, also in Mexico, in the European Union, and the United Kingdom, which is just recently not part of the European Union, unfortunately, and Switzerland, and then several other small countries. So that's Pfizer. And then next down the list is the Moderna vaccine. That's also approved for use in the United States, and it's being used today as we speak here in South Dakota, and that's an RNA vaccine, very, very modern technology. And I believe that process has been explained here in this lecture series previously, and that was done very nicely. And that's been, the Moderna vaccine has been approved in the United States and in Canada and in the United Kingdom and Switzerland, but not the European Union yet. And then next on the list is the AstraZeneca vaccine. And this is one where the coronavirus antigen is hooked up to another virus, the adenovirus. So it has a viral vector and injected. And I believe this is on schedule for review next week by the ACIP meeting. So this may be the next vaccine to be approved for use in the United States. So next Thursday and next Wednesday and Thursday, the ACIP will be meeting. And so that should be in the news next week. And this is already not approved in the United States yet, but it's been approved in the European Union, in Brazil, Argentina, the United Kingdom, India, South Africa, and South Korea too. So next on the list is the Johnson & Johnson vaccine, or the Jensen vaccine, a Swedish company. And that's also a viral vector vaccine, not approved yet in the United States, but the efficacy is, I'm reading a lot of things about the efficacy of it. A little bit confusing. It has not been presented, I don't think, to the ACIP yet, but it's suggested that it has about 85% efficacy. Then next on the list is the Sputnik vaccine. Well, this is the famous Russian vaccine that Putin has taken, and this is, of course, been approved and in wide use in Russia, Argentina, the United Arab Emirates, and in Mexico. And followed by that is the Sinovac vaccine, and this is the Chinese vaccine, which is 50% efficacy, and this is being used, of course, in China, Egypt, Pakistan, a few others. And then last on the list is Novavax, which is 89% efficacy, and that, I think, is just being used in the United Kingdom. So here in South Dakota, it's Pfizer and Moderna so far. Both their efficacies are in the good 90%, which when you compare that to vaccines that we commonly use, it looks very good. But what we're really waiting for now is the effectiveness studies. And right now, as we speak, starting in January, the efficiency studies, the efficiency assessments were actually being conducted already. And they're being conducted in 26 states, not South Dakota. So Sanford, Nevada, they're not involved in this, but they've got over 500,000 healthcare personnel. It's not just Joe Blow citizen, but it's actually healthcare personnel who all have 2 vaccines, 2 COVID vaccines so far. And just keep paying attention to the news, because it's going to take several months for this study to play out, and they'll learn a lot about the vaccine during this vaccine efficiency study. So I'm looking forward to that. And we're all watching all the mutations of this coronavirus that are being detected and how the vaccine is going to be able to prevent them. So there's a lot of fascinating science here, so stay tuned. So thank you. And I'm telling you this from frigid Pierce, South Dakota. Today is the 15th of February. And this is the view right out my window here. I'm looking at the Missouri River, which is frozen on the edges, but still has an open patch in the middle. I'm about 4 miles south of the dam. And when the dam lets water out, and then the river stays open. And the geese certainly appreciate that. But I don't see any fishermen out on the river today. So thank you. Thank you.